Benign breast disease describes non-cancerous disorders which affect the tissue of the breast. They encompass a heterogeneous group of breast lesions that may present with specific symptoms or be identified as an incidental finding. Despite a higher incidence in the female population, benign breast disease may affect both males and females. Benign breast diseases actually represent the majority of breast lesions, with around 90% of individuals who are referred to the breast clinic having a benign breast condition, as opposed to a malignant disease. Therefore, it's extremely important that we're able to assess and distinguish benign breast diseases from malignant conditions. So starting with some anatomy, the breast is an exocrine gland, which is responsible for the production and the secretion of milk. It consists of both glandular and fatty tissue, and the proportions of these two components varies for different individuals and also alters with age, with a respective greater amount of fat in older patients. The breast itself lies between the second and sixth rib anteriorly, and it extends from the edge of the sternum to the mid-axillary line. With regards to the underlying muscles, the breast tissue lies upon the pectoralis major and the serratus anterior on its lateral aspect. The breast is anchored to the pectoralis major muscle by suspensory ligaments that are named after the famous English surgeon and anatomist, Sir Astley Cooper. And in fact, these suspensory ligaments of Cooper become more loose and stretch with increasing age, and this is a significant contributing factor to the breast becoming ptotic or low-hanging as the patient gets older. As we can see, posterior to the nipple and the areola, the breast is composed of a complex tree-like structure, and this has the purpose of creating and secreting milk during lactation. The leaves of this tree-like structure are called lobes, and there are about 15 to 20 within each breast. And in turn, each lobe contains lobules, which are made up of collections of milk-producing alveoli. Each lobule has its own lactiferous duct, and this is responsible for carrying the milk from the lobule to the nipple from where it can be released. The blood supply to the breast is derived from several arteries. The majority of its blood supply comes from the lateral thoracic artery, which is a branch of the second part of the axillary artery. Additionally, the breast is also served by the internal thoracic artery, which we also refer to as the internal mammary artery. However, it's also supplied by the posterior intercostals and the thoracoacromial artery. Moving on to the lymphatic drainage of the breast, as we can see, this is relatively extensive and involves the anterior drainage by the pectoral nodes, posterior drainage via the subscapular nodes, lateral and medial lymphatic drainage is via the brachial and the internal thoracic nodes respectively, and in addition to these, the breast is also drained via the infraclavicular, the central, and the apical nodes. So you can definitely appreciate that the lymphatic network for each breast is really extensive. To better understand benign breast disease, we first have to understand the 3 stages of breast development. The first stage is referred to as the development stage, and as the name suggests, involves the development of the breast from its embryological starting point up into the pre-puberty stage. The second stage is the cyclical stage, which commences at puberty and involves the development of mature breast tissue, the lactiferous ducts, and also the milk-producing lobules. It's within the cyclical stage that hormonal changes during both puberty and pregnancy result in structural and physiological changes within the breast tissue itself. And these cyclical breast parenchymal changes continue until we reach the third and final stage, which are referred to as the involution stage. This occurs in postmenopausal women and results from a decline in the levels of estrogen and progesterone, which culminates in atrophy of the mammary gland tissue and irreversible structural and physiological changes to the breast. And it's important to be aware of these three stages, because the majority of benign breast diseases can be attributed to problems which occur within one of these three stages. As mentioned in Part 1, benign breast diseases make up the majority of breast lumps and abnormalities that patients may present with. Benign breast disease can be divided into three categories: congenital abnormalities, aberrations of normal breast development and involution, or ANDI, and lastly, non-ANDI conditions. The incidence of benign breast disease rises during the first 2 decades of life, and then tends to peak within the 4th and 5th decades. Importantly, this is in contrast to breast malignancy, in which the incidence continues to increase after the patient has undergone menopause. The approach we take when dealing with a presumed benign breast disease is the same as that which we adopt in any patient who has a suspicion of breast malignancy, and that is the triple assessment approach. Triple assessment involves, as the name suggests, a threefold approach. This includes taking a thorough clinical history and performing a clinical examination, undertaking radiological investigations, which may involve either a mammogram for patients who are older than 40, or an ultrasound in patients who are less than 40, although it's worth noting that the age cut-off point for patients and the decision as to whether they get an ultrasound or a mammogram may actually vary depending on local departmental guidelines. And the final step in our triple assessment is to carry out a pathological investigation. This can be performed either with a core biopsy, which allows histological examination of a specimen, or we can undertake a fine needle aspiration, which enables a cytological examination. It's important to note, however, that core biopsy has largely superseded fine needle aspiration, as it provides far more useful architectural information about the breast lesion that we're examining. As we mentioned, benign breast disease can be divided into 3 groups, and the first of these groups that we'll start with is congenital abnormalities. The most common congenital abnormality of the breast are supernumerary nipples and accessory breast tissue, and breast hypoplasia. Accessory nipples and breast tissue affect approximately 1% of the female population. They occur at any point on a line, which extends from the axilla down into the groin. We refer to this line as the milk line, as its presence indicates the site of the ectodermal mammary ridge, which forms during embryological development, and upon which the breast bud develops. Whilst accessory nipples and breast tissue can occur at any point along the milk line, the most common locations for them to be found are in the axilla and in the space between the breast and the umbilicus. In terms of how we manage accessory nipples and breast tissue, this mainly involves reassurance of the patient. However, in cases where patients may be symptomatic from the presence of the accessory nipple or breast tissue, or if they're unhappy because of the cosmetic impact, then we can offer surgery to remove the abnormality. However, it's important to make the patient aware that surgery in this instance comes with quite a challenge in achieving a good cosmetic result. Another additional point to be aware of is that accessory breast tissue does potentially carry the risk of developing a breast malignancy. Therefore, in cases when a non-operative approach is adopted, it's important that we make sure that these sites are regularly examined by the patient and also form part of our general breast examination and screening. The second congenital abnormality we should be aware of is breast hypoplasia, which is characterized by the failure of one, or in rare instances, both breasts to fully develop. This may be congenital, but it can also be acquired. In congenital cases, breast hypoplasia may be accompanied by the underdevelopment or complete absence of development of the pectoralis major muscle, a condition which we refer to as Poland syndrome. Acquired cases of breast hypoplasia occur as a result of insult or injury to the developing breast, and examples of this include radiotherapy or trauma. In terms of how we manage breast hypoplasia, as was the case with accessory breast tissue and nipples, this involves primary reassurance of the patient. And then, in cases where there's a significant asymmetry, we may perform breast augmentation of the smaller breast. Or, if there's a very minor correction that's needed, we may choose to perform autologous fat filling. ANDIs, or aberrations of normal development and evolution, represent a wide spectrum of benign breast diseases, which arise as a result of normal physiological processes within the breast. These include fibroadenoma, phylloides tumours, breast cysts, nipple discharge, and breast pain or mastalgia. Typically, the incidence of ANDIs begins to increase in the first 2 decades of life, and they peak around the 4th to 5th decade. Fibroadenoma is the most common benign breast lump in premenopausal women, primarily affecting women between the ages of 15 to 25. It occurs as a result of benign hypertrophy of breast lobules. And in fact, the prominence of the fibroadenoma may actually change during the individual's menstrual cycle or as a result of pregnancy. The typical characteristics of fibroadenomas are that they are very mobile, smooth, and discrete in nature. So essentially, it's clearly distinct from the surrounding breast tissue. It's these characteristics, in particular the high level of mobility during clinical examination of the breast, that have led to fibroadenomas also being referred to as breast mice. We investigate fibroadenomas with triple assessment, as we mentioned earlier in this tutorial series. Importantly, we need to perform ultrasound imaging of the breast, typically with a core biopsy done as well, especially in patients who are older than 25. Once the diagnosis of fibroadenoma has been established, our management consists of providing reassurance to the patient and explaining the benign nature of the condition. However, if the lump rapidly grows and causes symptoms, or if the patient requests, then we can perform a surgical excision to remove the fibroadenoma. Our next ANDI is phylloides tumours, which typically affect patients who are older than 40 years of age. Phylloides tumours, which may also be known as cystosarcoma phylloides, are largely benign tumours, whose name comes from the Greek word phylloides, which means leaf-like, and refers to the fact that the tumour cells grow in a leaf-like pattern. Phylloides tumours tend to grow very rapidly and present as a relatively large, discrete lump, which in some instances may distort the breast, causing venous engorgement or even breast ulceration. Whilst the majority of phylloides tumours are benign, they may be locally malignant, but thankfully only rarely will they result in metastasis, with this occurring in less than 5% of cases. We investigate phylloides tumours with triple assessment, and in particular imaging in the form of a mammogram, an ultrasound, and also an ultrasound-guided core biopsy, to help us determine whether the tumour is benign or has malignant features and potential. Once the diagnosis has been established, our management consists of surgical excision of the phylloides tumour, during which it's essential to ensure that it's completely excised, with a clear margin of normal tissue surrounding the tumour to help prevent any recurrence. It's then important that any patient who undergoes surgical excision of their phylloides tumours is regularly checked in the outpatient clinic to help ensure that no recurrence occurs. Breast cysts are another key ANDI. They typically affect patients who are between 20 to 50 years of age, and they're caused by the cystic enlargement of the end lobular units of the breast. Breast cysts may be simple in nature, or they can be more complex. However, regardless of their structure, they typically present as discrete palpable lumps, which may be tender during physical examination. We investigate breast cysts with triple assessment, which includes carrying out ultrasound of the breast. And with thicker walled or more complex cysts, we should undertake a core biopsy to help exclude any malignancy. Once the diagnosis of a breast cyst has been established, our management should involve reassuring the patient. And in cases of very small cysts, these may simply be left alone. However, with larger and more symptomatic cysts, we can perform aspiration of the cyst under ultrasound guidance. We should be aware that in cases of more complex-looking cysts, there is a small risk that they may actually be something more sinister and could potentially be malignant. Therefore, regular follow-up and screening is really important. So those are the first three of our ANDI group of disorders. We'll continue our discussion on the remaining ANDIs in the next part of this tutorial series. The next of our ANDI benign breast disorders that we're going to look at is nipple discharge. Nipple discharge can be either physiological or pathological. So let's compare the two in more detail. In terms of the causes of physiological nipple discharge, it can be either lactational or related to hormonal fluctuations and imbalances. From a pathological side of things, the discharge may be as a result of intraductal papilloma, which is a small benign tumour that forms in the milk ducts of the breast, or it may be as a result of duct ectasia, which is a benign condition in which the lactiferous ducts becomes dilated, its wall thickened, and the subsequent blockage of the duct leading to accumulation of fluid. And it's this fluid accumulation that can result in swelling and the secretion of discharge from the nipple. In terms of how the various nipple discharges may occur, in physiological conditions, the onset is typically bilateral and is non-spontaneous, which means that for discharge to occur, the fluid needs to be expressed from the breast. Whereas in pathological nipple discharge, it commonly affects only one breast. But very occasionally, it may be bilateral. However, the onset is typically spontaneous, so it occurs without the need for expression of the fluid. With regards to what the nipple discharge appears like, in physiological discharge, the secreted fluid is typically milky or cheese-like in nature, whereas in pathological conditions, the discharge is most commonly serous, or maybe bloody or blood-stained. As with the majority of breast disorders, we investigate nipple discharge with triple assessment, and in addition, we can also perform an initial analysis of the fluid with a urine dipstick to check for the presence of blood. We can also measure the patient's serum prolactin levels, especially in patients who have bilateral milky discharge, as this may rarely be an indicator of the presence of a prolactinoma or a very specific pituitary tumour. In terms of imaging the breast, we typically perform this with an ultrasound. And in addition, we can also perform an ultrasound-guided core biopsy if the ultrasound identifies the presence of a mass. However, rarely we can also perform a mammary ductoscopy, which is an adjunctive investigation that involves endoscopic examination of the lactiferous ducts to identify any abnormalities that may be missed on conventional imaging. But also, it means that if we do identify any abnormalities, then we can perform collection of the epithelial cells of the duct. After our investigation, our management options depend on whether it's a physiological or a pathological cause of the discharge. In cases of physiological discharge, the primary management is with reassurance and potentially correction of the cause of the physiological imbalance. And if the patient has significant symptoms, then we may offer a total surgical excision of the lactiferous ducts. In pathological cases, in particular intraductal papillomas, in young patients, we can perform a microductectomy, which involves the surgical excision of the specific lactiferous duct in which there's an abnormality, and this should solve the problem. However, in older patients with intraductal papillomas, who aren't concerned about any future breastfeeding, we may perform a total duct excision, so excision of all of the lactiferous ducts. And in the case of ductectasia, we would also likely choose to perform a total duct excision, and this should allow us to completely resolve the patient's symptoms. Our final ANDI is mastalgia, or breast pain. This is regarded as a benign condition once we've ruled out the presence of any underlying pathological conditions that may be causing the patient's symptoms. Mastalgia may be cyclical, with fluctuations in the severity of the pain, or it may be non-cyclical, with more persistent and consistent symptoms. The presence of breast pain may be related to hormone levels, and it's not uncommon for the symptoms to fluctuate and follow the normal menstrual cycle of hormonal changes. It's important to note that most cases of mastalgia are self-limiting in nature. However, even so, we should always assess these patients with our triple assessment approach. But thankfully, it's only very rarely that a pathological abnormality is present that warrants any pathological assessment. In those individuals who are older than 40, we should be undertaking imaging in the form of a mammogram. And in those patients who are younger than 40, and in whom we find abnormalities during clinical examination, for example, significant nodularity, then we can perform imaging investigations in the form of an ultrasound. However, in younger patients with breast pain, in whom we find no physical abnormalities on clinical examination, and no concerning features in their history, then we don't need to perform any imaging investigations. In terms of how we manage patients with mastalgia, an important approach is to reassure the patient and deal with lifestyle factors. For example, ensuring that they reduce their caffeine intake, which has been shown to reduce the severity of pain. As well as this, we should ensure that the patient has a supportive bra, or is in fact wearing the correct bra size, to ensure that the bra is providing the breast with the maximum support possible. In addition, we can also use topical or oral analgesia, which can significantly reduce the impact of the symptoms. And in some cases, we can use medications such as danazol, which has anti-estrogen and androgenic effects, and can offer significant relief of symptoms in patients with severe mastalgia and symptomatic breast nodularity. Our final group of benign breast disorders is the non-ANDI group. These include breast infections, fat necrosis, and gynecomastia. Breast infections include mastitis, so inflammation of the gland or breast tissue, or breast abscesses. We can divide breast infections into lactational, in which the infection coincides with the breast producing milk, or non-lactational. Lactational-related infections typically present with breast pain, swelling, and erythema. However, the important point to note is that these signs and symptoms occur at the same time as the patient is breastfeeding. Typically, lactational breast infections occur as a result of the break of the skin in the nipple area, and this allows bacteria to enter the breast. The nutrient-rich maternal milk is a great environment for overgrowth of bacteria, and this can be made even worse with overproduction of milk and the stasis of milk within the duct. And these factors can all contribute to the development of mastitis. We manage lactational breast infections by giving analgesia and using appropriate antibiotics, such as a penicillin. It's important to inform the patient that the presence of a lactational breast infection does not mean they have to stop breastfeeding. And in fact, expressing of milk on the affected side can actually help to relieve the stasis of milk, and thus it can help drain the breast and clear the infection. Non-lactational breast infections typically affect patients who are age 40 or older, and it's more common in individuals who smoke. The presenting symptoms will be the same as those with lactational infections, so namely breast pain, swelling, and erythema. The breast infection occurs as a result of dilatation of the subareolar ducts, resulting in stasis of the secretions and the onset of bacterial overgrowth and infection. And this infection may rupture into the surrounding tissue and result in a more diffuse inflammation of the breast. It's important that we investigate non-lactational breast infections with triple assessment, and in particular the use of ultrasound, to help rule out the presence of an underlying abscess or inflammatory breast cancer. Once we've done this, our management includes analgesia and the use of a broad-spectrum antibiotic. In cases where a breast abscess is identified, it's important that we try to avoid performing any incision and drainage, because of the significant risk of a poor cosmetic outcome with this type of intervention. Therefore, we primarily treat breast abscesses with ultrasound-guided needle aspiration, as well as the administration of broad-spectrum antibiotics. And in most cases, this combination of interventions allows the abscess to completely resolve. Our next ANDI is fat necrosis. Fat necrosis usually occurs due to blunt trauma to the fatty breast tissue. For example, following a seatbelt injury sustained after a road traffic collision. The trauma results in bleeding into the surrounding breast tissue, and this may in turn consolidate and result in a palpable lump. We investigate fat necrosis with triple assessment, and in particular the use of ultrasound and an ultrasound-guided core biopsy. Once triple assessment has confirmed the diagnosis of fat necrosis, we typically manage these patients with reassurance and conservative management, and usually the palpable mass will resolve over time. Okay, so we've covered the first two of our non-ANDI breast conditions. In the next part of our tutorial series, we're going to look at our last non-ANDI, which is gynecomastia. Gynecomastia is hyperplasia and hypertrophy of the ductal and stromal tissues of the breast in a male patient, and it presents as the development of visible breast tissue in boys or men. Gynecomastia is regarded as a benign breast condition once we've excluded the presence of any underlying occult condition. The causes of gynecomastia may be broadly divided into physiological, pathological, and medication-related. Physiological cases of gynecomastia may occur in neonates, individuals undergoing puberty, or in the elderly, and typically occurs as a result of normal hormonal changes or imbalances. In terms of pathological causes, the development of gynecomastia may be an indicator of increased estrogen levels, for example in those individuals with testicular tumours or bronchogenic carcinomas. Or alternatively, it may be an indicator of the presence of decreased androgen levels, for example in those patients with cryptorchidism or hyperprolactinemia. So it's really important that we have these potential pathological causes in our mind when we approach any patient with gynecomastia. Medications are a really important cause of gynecomastia, and in fact it can occur as a result of a wide array of drugs. And the full discussion of which drugs can be responsible for this condition is well beyond the scope of this tutorial. Some of the most common classes of medications that can cause gynecomastia include anabolic steroids, hormonal therapy, antiandrogens, for example finasteride, certain cardiovascular medications, including spironolactone and digoxin, and also psychoactive medications, such as clozapine. As is the case with all benign breast conditions, it's really important that we assess patients with gynecomastia with the triple assessment, and in particular, make sure we undertake a thorough clinical history and a medication history. We should then also perform a detailed clinical examination of both breasts and the genitals to look for the presence of any pathology and testicular lumps. Additionally, We should also perform imaging investigations, primarily in the form of an ultrasound, to help exclude any occult breast lesions. The management of patients with gynecomastia is dependent on the underlying cause. If the underlying cause is medication-related, then where we're able to, we should aim to stop the offending medication. If patients have a pathological cause to their symptoms, then it's obviously important that we treat this in an appropriate and expedient manner. And in those patients who have no sinister cause for their condition, then it's important that we reassure them. However, in patients who are particularly symptomatic or troubled by the condition, we may consider the use of surgery to help correct the gynecomastia. However, with the surgical approach, it is somewhat challenging to achieve a good cosmetic result, and therefore it's really important that we counsel the patient and aim to ensure that they have a realistic view of what surgery can achieve to help prevent any disappointment. To summarise what we've covered in this tutorial series on benign breast disease, benign breast diseases are a heterogeneous collection of disorders that are particularly common, with benign breast disease being responsible for about 90% of all clinical presentations that are referred to the breast clinic. We should approach benign breast diseases with the triple assessment, which includes taking a clinical history and performing a clinical examination, undertaking radiological investigations, most commonly in the form of a mammogram or an ultrasound, and finally, carrying out a pathological investigation, typically in the form of a core biopsy. Benign breast diseases can be divided into congenital abnormalities, aberrations of normal breast development and involution, or ANDIs, or non-ANDIs. Whilst most benign breast diseases can be treated with reassurance and medical management, we also covered cases in which surgical intervention may be appropriate. And having a good knowledge of these options, and when each is suitable, is really important.